Oh, yeah. Fine. So happy for me to start.
Yeah, go ahead.
Cool. So we're going to talk about trans reproductive health today. Um, and what are we going to discuss? We're going to discuss Transparent Day, which is why we're talking about this in the first place. Trans family planning, obstetrics for trans masculine people, and inclusive environments for trans patients. That's something that we've talked about a bit before, but sort of rehash it again. So what is Transparent Day? So it's the first Sunday of November every year. It's basically an alternative for Mother's and Father's Day for people who either don't feel that they fit into Mother's and Father's Day, or just to have like a separate day for specific issues that trans parents have got. Um, and in general, it sort of shows support and provide resources for trans parents. And why are we talking about it? The day itself talks about is partly so that trans parents are involved in discussions around parenting, but in medicine as well. Trans parents and trans patients in general are often left out of discussions to do with pretty much anything. And if anyone's done year four women, child, and family in Cardiff, then you know that you don't hear much about trans parents at all. So it's just a worthwhile thing to talk about. So considerations of trans family planning. I think the main thing is when we talk about trans patients at all, I think it's trans patients have very similar issues and often exactly the same issues as cis patients and literally everybody else. And in the same respect, trans people might want kids in the same way that everybody else might want kids. But why? How might it be different? So, if someone takes gender affirming treatments, they often affect fertility somehow. In general, the topic of reproduction is quite what can be quite dysphoria inducing, can be quite uncomfortable. And reproductive health services as a whole may also contribute to feelings of dysphoria. But overall, trans and non-binary people have a right to reproductive services that match their needs, and it starts from sort of recognizing what those needs might be, or where those needs are different from, not people who are trans and non-binary and things. So for the rest of it, we'll just talk about like what some of these things are, like what some of the differences are in needs, and then how we can sort of start to make the environments a bit more inclusive for trans people. So, gender affirmation fertility in general. So, if you have a surgery that removes the uterus or testes, that might eliminate, but it does just get rid of fertility altogether. So, if you don't have a place to grow a child or things to produce, like, um, you know, sperm, then that's going to eliminate fertility unless you sort of kept some sperm aside beforehand. And that's the same for the ovaries. So if you haven't kept some eggs beforehand, you're going to lose that fertility if you get rid of them. But I haven't added the ovaries here just because removing ovaries doesn't necessarily mean that you can't grow a child, kind of thing. You can get rid of them but keep the eggs, kind of thing, and then then grow a child. Um, so think about so that's surgery with gender hormones. We don't really know altogether how it affects fertility. Um, but we do know that over time, if somebody takes testosterone, that can reduce their egg development, and it does stop ovulation and menstruation. And we also know that estrogen reduces or stops sperm production, but like the extent to which these things are reversible or whether or not they are is not really understood. So like some trans men can stop taking testosterone for a particular amount of time, then start ovulating again. Some of them can't, and it's not really clear why and when. Same with some trans women and trans feminine people. If they take estrogen for a long time, then testes can literally change shape histologically, then might stop producing sperm altogether. But again, it's like nobody knows what that cutoff point is. That's just like a trans people aren't researched enough in healthcare or medicine. But maybe that's just something that'll elucidate in the future, but who knows? But it's basically for these reasons that before trans people or non-binary people who want to start taking hormones. It's recommended that they store gametes somehow. But sort of gamete storage is a whole other talk. It's like it can be quite awful for people to do, especially if you're sort of preserving eggs. It's not a pleasant thing. And a lot of people, they've waited for years and years and years to start hormones. They don't really want to wait like an extra few months to, delay it even further. But fine. So, obstetrics for transmasculine people. I think that's probably this is going to be the bulk of the talk. Mainly because the reproduction on that side is a bit more complicated in general. So trans and non-binary people may avoid obstetrics just as other health services. I think we know that trans people and non-binary people have worse health outcomes in general just by virtue of being trans, because the health system just doesn't treat them very well, so they avoid them, which makes sense. And with obstetric services and gynecology services, that's sort of exemplified even more because it's a very sort of feminine environment that a guy might not necessarily feel comfortable going into. So to show that, like, Mid and South Essex NHS Trust report showed that 30% of trans and non-binary people who were pregnant didn't access antenatal care at all, and that's compared to about 1% of non-trans and non-binary people. And why is that important? Because if you don't access antenatal care, then you can't access all the screenings and the scans and the things to actually make sure you're healthy during a pregnancy, and also after the pregnancy and during birth and stuff. Like all the horrible stuff that could happen is at a higher risk of happening. And also, sort of on a more somber note, people who can get pregnant sometimes do get pregnant, and then the support after, if you don't want that pregnancy to happen, getting rid of that pregnancy is often extremely unsupported for trans men and non-binary people, and that's especially true for things like miscarriage and that sort of thing. So that's just not, it's not a very nice thing for trans men and non-binary people to go through when the support that should be there just isn't. And of course, the understanding that it should be there also isn't. Fine. So some more general points then. Testosterone is not a contraceptive. A lot of people think that, like, because testosterone stops ovulation and stops menstruation, that therefore it means that a trans man who's taking testosterone can't get pregnant. That's not true. He can. So if you're discussing, with a patient who does have sex in a manner which may lead to pregnancy, then you want to say, like, the same things that you would have done before, you need to do again, or keep doing. And again, sort of on the topic of egg storage or gamete storage, you can become pregnant if they're in if you get rid of the ovaries, for example. You can then become pregnant if you choose to. So you can do something like IVF. So if their eggs are stored or through like something like IVF. Another thing, testosterone is directly teratogenic. So if you find out you're pregnant, or if trans man finds out he's pregnant, he needs to stop taking testosterone straight away, just because it can cause the sort of fetus harm and therefore more potential to cause him harm. And indeed, like, if somebody is planning to get pregnant, who's taking testosterone, I think the Royal College of Obstetricians and Gynecologists draft guidance that was the draft was done over a year ago and hasn't actually been released yet. But on it says, stop taking testosterone about 3 months before actually getting pregnant, because otherwise there's still a risk of harm to the fetus. A bit more. As we were talking about with terminations and miscarriages and things, if you're not planning to have a pregnancy in the first place and if you're a transmasculine person, it can, be one of the worst things that could happen, because then you have to go through access the services that are already unsupported, or you're already feeling just rubbish because it's happened and that kind of thing. So if we ever see a patient who's transmasculine and is pregnant but doesn't want to be, you need to sort of recognize that they really don't want to be. I need to have that discussion with them carefully. And afterwards, so this is all from the Royal College of Obstetricians and Gynecologists draft guidance. Again, it hasn't been released yet, but draft guidance. Just because a trans man is a trans man, it doesn't mean that he might not want to. He doesn't want to feed the baby in the same way that a cis woman might. So discussions about feeding should be exactly the same. I think a lot of people, it is recommended to not use the word breastfeeding. Say something like chest feeding if they prefer that. Again, like if you don't know, ask. Just because it might help help someone feel a bit more comfortable. And also just like testosterone, the effect of testosterone on sort of human milk is not really known. I think that's just that. I don't know if it crosses into milk or if it does, if it then does anything to the child that's drinking it or whatever, but it's just to be aware of. Another bit I should have added, if a trans man has had top surgery, he still might be able to chest feed. And that's just something to be aware of because top surgery doesn't actually remove like all breast tissue. It leaves some behind, and that therefore some milk might still be produced. But that's the same with like, a cis man who has breast tissue and some out of somewhere gets like, I've forgotten the hormone, but milk hormones still might produce milk. But just to be aware of. Fine. That's that. At the end, to finish off with just like the general bits. How do we have inclusive or make inclusive environments for trans patients? So this is stuff that we've probably gone over in some of the other teachings, but it's important to go over every time. So ask about language before using it. I think with this one, it's like breastfeeding and chest feeding. Not everyone feels the same way about particular terms, so just ask. And that's the same with having discussions about like gynecology or sexual health and everything else. If they want their genitals referred to in a particular way, use those. I think don't use colloquial terms for genitals or like chest tissue that might make someone feel uncomfortable just because other people don't feel uncomfortable with it, kind of thing. Just make sure you ask before you use something. And then like as expected, if someone asks for a type of language to be used or particular words to be used, then use it and remember it, and then tell people tell people around like this is what they like to use, this is the kind of language that they like to use. So yeah, reproductive health services, as we say, can be intentionally gendered, so that can add it to the like feeling the need to avoid them and generally feelings of discomfort when you're actually accessing them. So things that can help are sort of using language that's more inclusive when you speak to people. So I think it's like the same thing as like pregnant women and pregnant people, or pregnant patients. It's just like you can say, it's not eliminating anyone just to say like pregnant people or pregnant patient, just adding people in. But even if you like to say that, so you can use additive language like pregnant women and people, just to sort of add people onto the end, just to make sure that people actually feel included by it. And then the sort of bits that we mentioned before, just like have symbols of support dotted around the place, like trans pride flags on notice boards in waiting rooms and things like that. And one thing I did mean to mention as well, like one thing, it's illegal. So if you've got a trans patient and they tell you they come out to you as being trans, and then you go off and tell other people, that's against the law. So it's illegal to out someone to other people without their consent. But in a setting like this, say for example, a trans man was giving birth and you see him first and you say he tells you that he's dad and wants to be called dad, then you tell other people like, okay, he's dad, don't call him anything else other than dad. That's fine. So that's not like outing as such, it's just saying this is what it wants to be called, kind of thing. But that's like, again, more general advice. If you see a trans patient and their name is wrong on their label and they say, well, actually, I want to be called this, then you can ask their permission to then tell everyone else, like, do you want me to tell everyone else that you want this name to be used to refer to you? And then if they say yes, then fine. Then you tell everyone else, and then they do it, and then it's just easier for them. Problem solved. Fine. That's the end. Went through that quite quick, but are there any questions, or is there a discussion that wants to be had, etc.?
That was really good. Thank you, Leighton.
Yeah, well done, Leighton. It was so
Thanks,
interesting.
Holly.
That yeah, the way like language can be so kind of powerful and helpful to be inclusive was really interesting. So yeah, thank you so much.
All right.
If people don't want to ask questions with the recording on, I can stop the recording and then we can have a discussion. Do you think that's better, Leighton?
Yeah, just in case, maybe.